Okay, so again, for those of us who practice in the delivery suites, hemorrhage is not an uncommon thing that we come into contact with, and it can certainly ruin somebody's day. There'll be days like this. Um, it's estimated, I think, that between 3 and 5% of all pregnancies are complicated by some form of hemorrhage in and around the time of delivery. Our definitions for postpartum hemorrhage have changed over the last several years now. We define a hemorrhage as a cumulative blood loss of greater than 1,000 cc's, or blood loss with signs and symptoms of hypovolemia within 24 hours of delivery. This includes intrapartum and postpartum blood loss, and this is regardless of route of delivery. Previously, we had different diagnosis of 500 cc's of blood loss after vaginal delivery, but hemorrhage would only be considered 1,000 milliliters after a C-section. So that being said, any blood loss during a vaginal delivery of more than 500 cc's, even though it may not quantify for a postpartum hemorrhage, should raise concern and put everybody's antenna up a little bit to be aware of that particular patient. In postpartum women, signs and symptoms of blood loss, such as hypotension and tachycardia, may not be present until blood loss is substantial. Remember, many of our pregnant women are young and otherwise healthy at baseline, and their bodies can sustain a reasonable hit before they actually start showing signs and symptoms of significant blood loss. A patient who does start having episodes of hypotension with tachycardia, bear in mind that you could already be behind the 8 ball in these patients, because this could represent up to a 25% or approximately 1,500 cc blood loss that was diagnosed or unrealized prior to this. And the main causes of postpartum hemorrhage are atony. Atony. But other things that you have to be aware of include things like cervical lacerations, which should generally be apparent at time of delivery or right after delivery, not something that would rear its ugly head, say 2 to 3 hours later, but you would never say never. So thorough exam to make sure you have not missed a cervical laceration as the cause for your ongoing blood loss. Any kind of retained products of conception can cause persistent and continuous bleeding until they are removed. Any type of accreta-percreta spectrum would be risk for ongoing blood loss. And oftentimes secondary to a major blood loss, DIC may be a potential reason for ongoing blood loss. Inherited disorders in terms of thrombophilias, etc. And what should be obvious would be a uterine inversion. That should be noticeable. Other risk factors for having a hemorrhage at time of delivery or postpartum include history of prior hemorrhage, any kind of inherited disorders such as von Willebrand's, prior invasive placentation, history of DIC. What's not on here is grand multiparity, polyhydramnios, large babies, multiple gestations, etc. And this table was taken from the ACOG practice bulletin on postpartum hemorrhage. The primary etiology of postpartum hemorrhage are abnormalities with uterine contraction or failure of the uterus to involute after birth, and which we call, of course, uterine atony. And these can be due to, again, prolonged use of Pitocin during pregnancy, high parity, infection, general anesthesia can relax the uterus, over distension, like we mentioned, twins, multiple gestations, polyhydramnios, large babies, Fibroids, which I didn't mention previously, especially multiple and large fibroids, can inhibit the uterus from contracting back down, leading to continued blood loss as the uterus cannot involute. And again, inversion should be visible at the time of a delivery. Oftentimes, short cord and fundal implantation of the placenta can be risk factors for having a uterine inversion. As we mentioned, you have to check the genital tract, looking for cervical lacerations, but also deep vaginal lacerations and perineal lacerations. These can occur at any point in time, but risk factors can be considered with operative delivery or very fast deliveries like a precipitous delivery. As we mentioned, retained placentas and placenta accreta spectrum. This is oftentimes seen when there is an accessory placental lobe that may not be known, and the placenta comes out and everybody thinks everything is good, and lo and behold, there's left behind a succenturiate lobe. Surgery can increase risk for partial accretas, so the entire placenta may not come out. And then abnormalities of coagulation, which can be acquired during the course of pregnancy, such as preeclampsia and HELP syndrome. They can be inherited for things like von Willebrand's disease, DIC, amniotic fluid embolism, all these sort of things that can either decrease or eat up our coagulation factors, can increase risk factors for blood loss at time of delivery and after. Again, taken from the FACOG practice bulletin on postpartum hemorrhage. When our patients come in, we want to assess what their risk is and kind of categorize them as low risk, medium risk, high risk. And then as they progress through the labor, delivery, and postpartum process, to continue to revisit these signs and see if perhaps they changed categories due to events that have occurred during the labor and delivery process. Low risk, as you can see here, would be considered a singleton pregnancy, less than 4 prior deliveries, no scarring on the uterus, and no history of any kind of hemorrhage. Medium risks, which majority of our patients probably fall into the medium risk category at least, include prior uterine surgery or C-sections, multiples, grand multiparity, fibroids, current infection, use of magnesium sulfate, prolonged use of Pitocin, and the very high risk are the known accreta spectrum, patients with anemia and hematocrits less than 30, ongoing bleeding at the time of admission, or known coagulopathy, and history of postpartum hemorrhage plays a big role into their risk for having that happen again. So what can we do to prevent hemorrhage? I'm not sure that there are a lot of things we can do to really prevent it, but making sure that we're at a high state of alert, especially for those patients that are at very high risk for hemorrhage, so we can intervene sooner. But there's some discussion about utilizing an active management of third stage of labor to help shorten that third stage of labor, including oxytocin use, traction on the umbilical cord, a uterine massage to get that placenta out, promote the uterus to involute, can potentially decrease your risks of ongoing hemorrhage. Many studies don't necessarily support any particular management strategy, but again, ongoing risk reassessment as a patient progresses through labor and delivery to see if their risk for hemorrhage increases based upon, again, events that have happened. Nipple stimulation, early breastfeeding doesn't seem to impact postpartum hemorrhage or reduce the risk of postpartum hemorrhage. As I've said multiple times, atony is the major cause for postpartum hemorrhage. Estimated 70 to 80% of all obstetrical hemorrhages are due to uterine atony, which we identify with brisk bleeding and a boggy uterus. as we are evaluating this and starting the management, things that you want to consider are making sure that the maternal bladder is empty, sweeping the uterus of the vagina for any kind of clots that may be remained. That uterus is not going to involute if there's a substantial clot burden still in situ. Again, inspecting for genital tract lacerations that may have been unseen previously. And then starting your medical management with a series of uterotonics that can be most effective in ending this episode. As far as uterotonics go and medications that we have to help decrease the hemorrhage and stop the hemorrhage and decrease maternal morbidity. Oxytocin, you can resume the oxytocin if it's been stopped after delivery, or give oxytocin via the IM route. Methogen is one of the most common go-to agents as long as the patient does not have hypertension. Hypertension or preeclampsia would be relative contraindication to giving Methogen. Hemabate, which is not a favorite of one of our nurses, but can be very effective as long as the patient does not have asthma or very reactive airway disease. And misoprostol is the other agent that doesn't have any substantial contraindications. It's kind of thought to be the first line agent for people who have both asthma and hypertension, but has somewhat fallen out of favor a little bit recently, as its time to action is not short. It takes about anywhere from 20 to 30 minutes to start working, and sometimes we need something to act a little bit more quickly than that. The dosage is anywhere from 600 to 1,000, either sublingual, buccal, or rectal. The rectal use, again, has kind of fallen out of favor just due to absorption. So the management, as in, is starting your urotonics as indicated and as based upon the patient's contraindication profile. And then TXA has been used in the last number of years, which is not going to affect uterine tone by any means, but as an antifibrinolytic agent, it can help decrease bleeding, and so it's not necessarily acting at the moment, but it is acting down the road. And again, taken from our BOI, subclinical birth outcome initiative slides, just a list of the medications that are first line use, and then second line use, and then TXA somewhere in there if the hemorrhage is not responding quickly. Once you start the use of your uterotonics, if you're still having significant bleeding with no signs of it stopping or slowing down, it might be time then to move towards one of our devices that we can place to help decrease the bleeding. Traditionally, the Bakri balloon has been used as a uterine tamponade, sort of filling back up the uterus and tamponading off those vessels that were feeding the placental bed. And that has had good success, but in recent years, there's been a newer device that has sort of taken favor. And that's the JADA system. It's very easy to place. We just did a training session in Orangeburg yesterday, and several of the doctors there had seen it but never used it, and gave some instruction on how to place it, and they were all very thankful for that, and pleased to see how easy it is to use. But essentially, it's inserted into the uterus, similar to the Bakri, although easier to insert. The cuff is inflated with 120 cc's of saline, and the suction device, the new device is put on suction, and the wall suction at 80 millimeters of mercury. Remember, 120 over 80 is a good blood pressure. And what this device does is it helps involute the uterus very, very quickly. It's helping perform what mom's physiology is currently not doing in terms of involuting that uterus. These devices have gained significant favor as of recent, and have become one of the first line agents, or first line devices to use, I should say, after the initial medication management is not as effective as necessary. So I guess I'll pause here and see if there's any questions or comments.
Okay, give me 1 second.